All right, people of the EMRAP universe, it's time for another COVID update. There's been some large movement in the field, but unfortunately, not much in terms of published stuff, but we have to talk about the unpublished or the barely published because people are out there talking about it. So I'm going to take you, I should introduce the other guy. Here's Swami. There's that guy.
Nah, it's not important.
Don't worry about him. It's all about me. First of all, culture scene. So a couple of days ago, we got this report in the news, and it went like this. You can see it here, perhaps on the slide, that they did this study of over 4,000 patients. There was a 25% reduction in hospitalization in patients given colchicine. There was a reduction in mechanical ventilation by 50%, a reduction in death by 44%. And I got to tell you, I'm like losing my mind. This is amazing. I then went back to clinicaltrials.gov to find out, well, who were these people? These were high-risk people over the age of 40. They were given colchicine 0.5 milligrams PO BID for 3 days, then 0.5 milligrams once a day for 27 more days. And these people, were pretty high risk. They had, uncontrolled hypertension, diabetes, obesity, that kind of things. All right, so far looking good, feeling very excited about it. And then there's the preprint comes out. And when the preprint comes out, it's like, oh, that doesn't look so good after all. So they found the overall composite endpoint when you put in death, hospitalization, making their ears grow smaller and all this stuff, that the number needed to treat was actually 100. And Swami's going to tell us in a second why it's not even as good as this. And the number needed to harm was just about 10 or 11. And the number needed to poo, which is a new one that I've come up with, was 15. For every 15 people you treat, somebody's going to have diarrhea. So these numbers don't look that great. And in fact, Swami, perhaps they're not even that good.
I don't think they're even as good as they're reported here. Overall, this is a clinically irrelevant trial, right? They didn't find any actual difference. The confidence intervals cross 1, which means nothing statistically significant. But Mel, this is kind of what we've been dealing with for the last year, right? Science by press release. And this one actually kind of rubbed me the wrong way even more because, when pharmaceutical companies do press releases, they kind of have to, right? I mean, it's their job. They have a responsibility to their investors, blah, 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 blah. But this was not a pharmaceutical company. This was a doctor at the Montreal Heart Institute who released this press thing saying that this is great. And then you look at the data and you're like, not so good. And it's only after they manipulated and played with their data that they found something that was actually beneficial. So what they did was they had, a bunch of patients, 3,500 patients or so, maybe a little bit more that they studied. And then they said, they went back and said, I'm going to take all the patients out who tested negative for COVID. So clinically they had COVID, but their PCR was negative. And when they took that group, they found a statistically significant difference for hospitalizations, but nothing for death, nothing for mechanical ventilation. So this was really an overblown press release trying to get us all in a frenzy about colchicine, which, Mel, I've never heard anybody try to get somebody in frenzy over colchicine, except for the toxicologists who are like, please, 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 please do not prescribe this drug. I mean, if we had Sean on here right now, he would be, he would be doing something to ward off the evil spirit of colchicine, because we know lots of toxicity with this drug. The doses here were pretty small, but no real benefit.
So did they say why they got rid of those people who are clinically COVID positive, PCR negative? Because that's really common. We know these tests miss at least 20% of people. So they just sort of excluded 20% of people who probably had the disease.
Yeah, I mean, they took these people who they said, early on, our tests were not very good and we couldn't get the tests back at a reasonable amount of time. So we put them in the study, but then we found they were PCR negative. And there's a part of that that's kind of reasonable, Mel. I mean, why would the drug be efficacious in a group that doesn't actually have COVID? But pragmatically, in real life, what's going to happen? We're going to give this drug to people who don't actually have COVID. They just look like they have COVID. And then it doesn't take into account all of the problems with the tests and the false negatives. So I don't think it's a legitimate adjustment to take that group out because it's not the way you set up the study. And again, pragmatically, it's not what's actually going to happen. But this is what we deal with now. We deal with these press releases. And I think it's really important is to understand that it's okay for the press release to come out. It's not okay for us to practice medicine based on a press release.
It'll be interesting to see once this goes through peer review and some people get to look at this in a bit more detail, what the final result is. Because the stuff I'm showing you here is from a preprint. It's not even peer reviewed yet. It's not been sent to a journal, or it may have been sent to a journal. But so we'll see if what comes out the other end of this. But this is a huge lesson for me that even when something looks fantastic in the press, It might not be.
I got to add two things. First of all, you said come out the other end. I'm assuming we're still talking about that NNP.
Yes.
That's one thing. But going back to the methodology, they actually did a good job. This is a well put together study. Let's be frank about that. Methodologically very sound. It's just a matter of what they did with their data after they collected it.
Okay, good. So you're not going to use colchicine tomorrow?
I'm not using it for myself or others.
No. I wonder if there's any other big studies going on, because there's a potential signal here. It's small and it's not going to change like the outcome for the vast majority of patients, but I don't know. I guess we wait for more stuff. So let's talk about full dose blood thinners. And this is actually from the NIH website. And it said this, and now I'm scared that this is going to be wrong too, because Swami's going to say, blah, blah, blah. Based on interim results of more than 1,000 moderately ill admitted patients to hospital, findings showed that full doses of blood thinners, in addition to being safe, were superior to the doses normally given to prevent blood clots in hospitalized patients with regard to the primary endpoint, which is the need for ventilation or other organ supportive interventions. This is the series of trials that they're talking about, REMAP and CAP and ACTIV-4 and ACTA. These are the trials that this is based on. Apparently, they've sort of combined these all together and come up with some results. They don't actually present the results, or didn't at the time that I got this yesterday. And they say here, the trial results reported today complement the group's findings announced in December that routine full-dose anticoagulation when started in the ICU in critically ill patients was not beneficial and may have actually been harmful. So what do I do with this information, Swami?
This is a tough one, Mel. We've been talking about anticoagulation for months now. We've talked about it with Sarah Krager. We talked about it with Tom DeLaury. We've had so many different people talk about this. What we know is that they need anticoagulation. If you're admitting them to the hospital, they need some anticoagulation. Prophylactic, therapeutic was what we were really discussing. And it kind of made sense to us. If they're really sick, they're intubated, they're going to the ICU, give them full dose of those anticoagulants. But the results of these studies coming out run contrary to that, saying that actually it's the moderate group, the ones that are kind of sick, but not super sick, that maybe the full dose does better. And I mean, I can wrap my head around a biological plausibility for this, right? The patients who are really sick going to the ICU, it's too late. They're clotty. You're not going to add anything by giving full dose. But the ones that are in the moderate group, maybe we prevent them from getting super clotty by giving them that full dose. But we do need to see the data here. I think, though, that this is a little bit different than those other press releases, because this is the NIH, and this is a group, these three studies, who are doing good high-level research, and they're releasing the information as they have it, but they're not trying to overblow things, right? And I think that's important. So, again, I would like to see actual data. I think we'd all like to see actual data to guide us. And then it comes back to, what do we do right now? What do we recommend people do with their admitted patients? I think everybody needs some level of VTE prophylaxis. I think that's an easy one. You admit them to the hospital, give them some VTE prophylaxis. If they're mildly ill, give them prophylactic doses, fine. If they're critically ill, I just talk to my intensivist and I say, what are you guys doing right now? What do you guys think is the best thing? And that moderate, that in the middle group, the people I'm actually asking about what to do for that group is the intensivist and our hematologists. What do I do with this group? He's moderately ill, or she's moderately ill. She's on non-invasive. She's not critically ill. Should I give him full dose? Should I not? And I think that's probably the best guidance we have right now until we actually have data to look at.
Yeah, everybody has been doing it slightly differently. When that first report came out that the sick people were getting worse, a lot of intensivists like, oops, that's who we've been giving it to. So I cannot wait to see these results, but this gives us a little bit more guidance about who to do it in. So let's move on then from the clotty bits, and let's talk about the Moderna vaccine and vaccine variants. I've been doing a lot of vaccine updates. I've been talking to Brown Baker and the people at This Week in Virology, some experts. So this is the big thing right now, that this virus is so prevalent. It's replicating so much. There are literally trillions and trillions of the copies of this thing. And so it is going to get modified over time. The great fear is that it's going to modify enough that the vaccines that we have are not going to be useful. So that's a real fear. So there's some good news that we have, mostly from the laboratory, and that is that the British variant that everybody's worried about, that appears to be more infectious, looks like it's covered very well by the current Pfizer and Moderna vaccines. And the way they basically do this is that they put it in vitro and they see if it's sort of gobbling up the virus spike proteins in. This is all very technical, Swami. And it looks like it works. It seems to grab that spike protein and we're all good there. The South African variant and now the Brazilian variant, and the South African variant appear to be very similar. It's a little bit more concerning there that if you saw Dr. Fauci last night, my time, talking about this, he said it's much more concerning that it's about 6 times less effective in the South African variant than in the UK variant. But because the levels are so high in most people, it looks like we're still going to be fine with the South African variant. And that's to say nothing of your other sort of immune responses. This is just antibody responses. But it is, it's very sobering that this thing could change enough that the next variant may not actually be covered. Now, the good news here, because of the way these mRNA vaccines are produced, they can actually tweak them. And he specifically talked about that they would still have to do like a phase 1 trial to see that they're getting an immune response. So they get, 100 people and see if you get a good immune response, but they would not have to do a 45,000 patient study to make sure that it is safe and effective. They would just go do a quick study to make sure you're getting an immune response, change the mRNA a little bit, and then just make that the next lot. Or if you've already had the 2 doses and there's a new variant out there that is not covered, you would have to get a booster. That's a big problem because we can't keep up right now with the number of vaccines that we have. Now, does that make any sense?
It makes sense, and I agree it's worrisome. I think the news so far is good. And again, this speaks to the power of the vaccines in that they produce this polyclonal antibody response. And so little variations on the spike protein are going to be okay, but if we get more and more of those, it's going to be a problem. And this is really for the masses in the public, not just for people listening to EMRAP, but it really underscores the need to do good public health, because that's the way you stop these variants from occurring. If you reduce the number of people who have the disease, then there are going to be less mutations, there are going to be less variants. So we really have to squash it and really tamp it down, which we're starting to do, Mel. We're starting to see some real drops, but they have to be sustained before we celebrate. And I'm worried. It's not that I don't want to get the booster. It's that, like you said, can we get the booster to everybody who's had it before? And are we going to see even more vaccine hesitancy and resistance if we're saying, well, we might have to give you another shot in 6 months?
Yeah, this is concerning, and it's just another reason why we want to reduce, the number of people that have this. It's also why the people are saying that we need to vaccinate the world, and this has some political implications. There are people that are saying, well, I don't want to have my taxes pay for some kid in Kenya to get their vaccine. Why would we do that? Why would we fund that? This is the reason. Because even if you just care about America and Americans and you just vaccinate all Americans and we're good, and this virus continues to run rampant in other places and they can't get vaccine, a variant will come from there and it will be vaccine resistant. And guess where it's coming? It's coming to America. So unfortunately, or fortunately, depending on how you look at the world, we're all in this together. We have to vaccinate the entire world to prevent it coming back to hurt you again. So that's very important to understand that. So when people say, just look after us, looking after us means look after everybody.
And Mel, there is some good news with the vaccines. I just got to mention, just recently saw in Reuters that they announced lower anaphylaxis rates than initially thought with the Pfizer vaccine. So I think about a week and a half ago, we were saying about 11 cases per million. And now they're saying about 5 cases per million of anaphylactic reactions. The Moderna's even lower. It's about 2 to 3. So I think that's some good news for people to take home of, these anaphylactic reactions, which were already very rare, are actually even more rare than we thought they were.
That is good news. And I should throw in there too, just sort of anecdotally from the Israeli public health societies. They are saying that I think they've vaccinated about 35% of the population so far. And even within 2 weeks, they're seeing dramatic reductions in admissions to hospital. And it appears from their data, and again, it's preliminary, that the vaccines are even more effective than they were in the trials, particularly for people over the age of 60. So they've already seen this huge reduction in the number of people going to hospital. So good news on the vaccine front. I just wish we could produce them faster and get them into arms faster. And I do have to bring this paper up. This was sent to us by Mark Fischk from Winter Garden, Florida. And this is scent dog identification of samples from COVID-19 patients, a pilot sample. Actually, what Mark sent was, the NBA is letting more and more people come and watch the games, and they're using dogs that will sniff you to see if you're got COVID or not. And is there any science to this? Well, I found this paper, which took a bunch of dogs and trained them from samples of people who are both positive and negative for COVID-19, and basically put it on rags and put their spit or whatever all over this stuff. And then they trained the dogs to tell the difference. And they were actually pretty good. These dogs got up to, and I can't remember, 82% sensitive and about 82% specific. Not bad, but far from perfect. And it also turned out that some dogs were excellent and some dogs just couldn't get it. Like, I don't know, it all stinks to me, mate. So there is some science here, but just know that this wasn't actually a study in people. This was just like samples, rags, probably really full of virus, and the dogs could smell some difference between whatever the proteins and stuff that were already also in there. This wasn't in a group setting like the NBA is doing. So I think the NBA is extrapolating beyond the data, but they always do.
And Mel, I don't want to. I don't want to just express my anecdote, my N of one, but I'm pretty sure that my dog would rather lick himself than smell people for COVID. So, not sure this is translatable very well.
Thank you very much for that insight. So, they're the updates we have for today. Do you have anything else to add, Swami?
You know, how much do you want to get into monoclonal antibodies? Because I think we could go down a real rabbit hole there. Let me, if you want, Mel, I can try. Let me try and summarize the monoclonal antibody stuff, because I think there's been a real push, the emergency use authorization for BAM and also for the Regeneron product. And I just want to kind of try to encapsulate the information we have, and we'll, have some links. People can read up more on this, but let's take BAM first. The big trial for BAM was Blaze 1. And what we had was an interim analysis, and then we had another interim analysis, and we're still waiting for the final analysis, although some data, I don't want to say data, some slides from Eli Lilly have been released. So when we look at the first interim, it basically said that the middle dose of BAM worked in reducing viral loads, no translation to any clinical benefit, never made much biological plausibility. And the second interim report basically tells us that it doesn't work. So no dose of BAM monotherapy reduced viral loads, no clinical benefit. So based on all of the evidence we have, there is no role for just using bamlanivimab or BAM as a monotherapy treatment for patients early with COVID. Now, in that Blaze trial, the second part of that was rolling out this cocktail. So bamlanivimab and another monoclonal antibody that I also can't pronounce, and seeing whether that has any benefit. And the interim analysis says, again, reduced viral load, maybe a reduction in hospitalizations, although even that is very sketchy at best. So no proven clinical benefit, maybe this disease-centered outcome. And then the Regeneron product, the publication is basically useless because there was no hypothesis tested. They were very clear about that. And we have no data guiding us on the use of that. And Mel, here's what I come back to over and over again. In that Regeneron study, they show that 45% of people who were early in their clinical course already had antibodies. Now, if your body has created polyclonal antibodies against SARS-CoV-2, why would we think that a couple monoclonal antibodies are going to benefit? It doesn't really make physiologic sense, or no biological plausibility there. And I think that's what we're seeing. These monoclonal antibodies probably aren't going to really have much of an effect once COVID is established. Whether they have an effect in post-exposure prophylaxis, we'll have to see. There are some dangers with that too, of if you give someone a monoclonal antibody for post-exposure prophylaxis, does that then limit the efficacy of the vaccines? We don't know the answer to that question. So right now, even though these both have emergency use authorization and we are giving them, there's no real data to drive us to give these. And Mel, I don't give them. I tell my patients very frankly, there's really no data to tell us they're beneficial. And we have no safety data at this point. We have no safety data on these drugs.
It's super confusing because, again, if I read the lay press, they say 70% reduction in mortality or hospitalization. I'm like, I keep looking for the paper that says that, and I don't know where it is.
It's not there. It's not there. That is the final Blaze 1 publication, which we haven't seen. But Eli Lilly has released their results. When I say, again, results, it really kind of hints that we actually have some data to look at, and we don't. They've just said what they found, but we don't know. I mean, this could be very similar to what we saw with colchicine. So we're going to have to wait for that. But at this point, there's really nothing that should be driving us to do this. And honestly, I think the only role for these drugs is in further trials. So ideally, if you had a patient who was eligible, you'd be able to get them into a trial, randomize them, and then get some real information. But we don't have that kind of a system in the US. We don't have the recovery trial like they do in the UK. And we're going to have to see what pans out with this. But right now, I don't see much of a role.
Okay. Anything else?
No. Have we sucked all of the hopefulness out of people yet?
Yeah. No, we haven't. Vaccines are good.
Vaccines are good.
And distancing, good. We should do that stuff. Actually, I should say one other thing. The CNN's been doing these town halls with CDC experts and with virology experts and with Dr. Fauci, and there was a really interesting discussion about masks. And the question was, should we be manufacturing millions, hundreds of millions of N95 masks and distribute them to people to wear, because we know that that would significantly reduce people getting infected. And I thought, yeah, that seems like a great idea. But the CDC director was saying she doesn't think that that's necessarily a great idea because of very practical reasons. Have you ever worn an N95 mask to work for 8 to 10 hours? It's almost impossible for healthcare workers to do it. It might produce a false sense of security, and people are going to be pulling it off because it's really hard to breathe and you lose your efficacy. Better that everybody just has a reasonably good mask that makes them feel good about themselves, a couple of layers of cloth that they can breathe through a little bit easier, have that 6 feet of distance, and you wear a mask as well, and that may be as effective or more effective. So there was actually a real science discussion about what type of masks people should be wearing. But for now, the decision is not N95s for everybody. And that actually made sense because before I heard that discussion, I'm like, of course everybody should wear an N95.
Yeah, I mean, Dr. Walensky is much smarter than we are. That's why she's in charge of the CDC. And I agree with her. I think in an ideal situation, we see this in other countries where everyone's got N95s on. We have a hard time sticking with cloth masks. It's going to be hard to think that we're going to do N95s. And I think that's part of the reasoning here is let's at least have some mask on instead of something that people aren't going to tolerate well.
All right, so there's your summary for this week. As we get more data, we will continue to do these updates. Thank you, Swami, for the time, and we will speak to you all soon. Please be safe and be well out there, and get your second dose if you haven't. Herbert out.